Let's go. Right, so today's session we're going to talk about just infection control in general dental practice. So first of all what we're going to do is we're just going to talk about the microorganisms that's involved in sterilisation processes within general practice, what we're trying to prevent against, and ultimately what the ultimate aim and responsibilities of us as clinicians and also dental staff in achieving is going to be. So there's three sections, three presentations. The first one is about the background virology and the microorganisms involved with infection control in dentistry. The second one we'll talk about the legislation, and then the third one is going to be more relevant in what we're going to be doing at the practice here. So this first section, the main aims have been identified as, by the end of the session, that you as a learner will understand the relevant infectious diseases to dentistry. You'll also have an understanding of the agents and their routes of transmission, and then also you'll have an introductory understanding of accepted protocols to prevent transmission and inoculation. We'll touch on inoculation injuries, but not in too much depth. That's another area we'll talk about in the future. So we've got learning objectives, which are going to be to demonstrate an understanding of the types of microorganisms present within a healthcare setting that we're trying to achieve sterilisation against. We're also going to define and understand the differences between the three main ones: hepatitis B, hepatitis C and HIV. So we're going to talk about microorganisms. What microorganisms are you aware of that we're trying to prevent against in dentistry?
Well, there's bacteria,
Yeah.
viruses,
Yeah.
fungi,
Yeah.
and
Any more?
prions.
Yeah. Prions. Very good. Very good. Gold star for that. So we'll come on to all those in a moment. But as governing bodies, the GDC, which is the General Dental Council, they stipulate in their standards guidance that we all have responsibilities with maintaining good standards of sterilisation within practice. It's mainly important because we have an ethical and professional duty to protect patients from patients, but then also each other from patients, and likewise vice versa, patients from us. We're also registered to always put patients' interests first as well. So the GDC have stated in their standards guidance that in their section 1.5 that you've got to treat the patient in a hygienic and safe environment, and that overarches the whole decontamination process, making sure that we decontaminate our instruments successfully, achieve adequate decontamination every time, not just some of the time, every time, and then also disposal of clinical and hazardous waste safely and effectively. They also say that we as clinicians and as auxiliary staff need to have all the necessary vaccinations to protect us against bloodborne viruses, so not only again from patients to us, but also us to patients. Right. Basically holistic protection all round. As a practice as well, we have a duty of care to the patients, but then the Care Quality Commission can at any time come and walk into the practice. They can shut us down through inadequate standards of cross-infection or sterilisation, and they have the overriding power to go and shut a practice down if they're falling short of expected standards. So, as you correctly said, we have various microorganisms we're trying to protect against in dental practice. So the main ones being those top three, so bacteria, viruses, protozoa, fungi, worms and prions. They all have varying abilities to be successful, and we'll touch on those in a moment. So bacteria, they are able to survive independent of a host. All that they require is nourishment, so they need some food, they need a bit of moisture, they need warmth as well, and they need the correct amount of time to multiply and divide, and then they'll form a colony like is on this petri dish. This is just a petri dish with agar. It's usually agar, so it's like a carbohydrate material that then the bacteria go and use as their nourishment, and then they'll just go and proliferate and go on form these colonies. Bacteria, coming on to viruses. Viruses aren't cells, they're merely just a chain of genetic material inside a protein coat. They require host immune system to multiply. So usually they command the host to multiply and divide and produce their genetic material over and over and over again, like a big production line basically. So they use the host mechanisms to multiply the virus genetic material. And the other big thing is that antibiotics are useless against viruses. So although the majority of the infections that we see, well, all the infections that we see in dentistry are usually bacterial-led, we can actually prescribe antibiotics to go and get rid of that, like infected teeth, pericoronitis, all this kind of stuff. We can give antibiotics against that. Never it's caused by viruses.
So with viruses, it just has to go through its course.
Yeah. So basically, with the cold virus, for instance, the immune system will recognise that it's a foreign body, and your immune system will combat it and go and get rid of it accordingly. That's why doctors don't usually give antibiotics for the common cold, because a lot of the time it's just a virus that changes its genetic makeup. Protozoa, it's a single cell with a nucleus. It's also classified as a parasite. There's 4 different groups according to the structure in the life cycle, but the most commonly well known is this, which is an amoeba. It's usually just a sack of material, and there's usually a nucleus inside. And this is actually the protozoa. It's called phagocytosis, so it basically pushes out 2 appendages around a foreign body and just engulfs it and then digests it. So this is basically how it processes material. And amoeba are probably one of the oldest organisms around still, so they're pretty hardy. Fungi, they're different from plants in that they don't contain any chlorophyll. So chlorophyll is the green stuff that you see on the leaves outside, so that's what differentiates fungi from plants. We have macroscopic fungi, such as mushrooms or toadstools, or there's big red ones with the white spots on. That's a fungi. But then there's also microscopic ones, which we'll classify as moulds and yeasts. And the majority of the problems we see, such as these, are caused by fungi. They're non-motile, so they don't move. They may grow as single cells, like yeast that you cook bread with, or they're filamentous structures. So again, if you leave your bread out, for instance, you'll get mould, and that's usually through hyphae or mycelium, which is this filamentous structure, and it basically takes over whatever host it's sat on. Clinically, ringworm is a mould, and this is evidence of ringworm here. But then also this is thrush, intraoral thrush. So candidosis or denture stomatitis is what you would have liked to have seen. So if someone's got an inhaler and they don't rinse their mouth out with water afterwards, they'll more often not get some kind of fungal reaction in the roof of their mouth, just because the inhaler changes the microbiology of that area and favours fungi development.
How do they spread?
They usually just basically grow. So, and sometimes they actually sporulate as well. So, if you look at it under the microscope, what they do is they go and produce these spores, and the spores go and spray off into the air, and then they go and create colonies elsewhere. So, I think that's how the bread ones go and grow. So they sporulate, they go and throw these spores out. They go and start another colony elsewhere, and then it just grows, and it all just merges together as one thing. So worms can cause infection and can spread from person to person, and examples of this can be threadworm or tapeworm. Not pleasant at all. You don't really want anything like that going on in you. And prions, as you correctly said, it's just a misfolded protein structure. So the best example is going to be Creutzfeldt-Jakob disease, and which is the human form of bovine spongiform encephalopathy, which is BSE for short. It's not considered to be a living organism, and it's responsible for the transmissible these conditions. So back in the late 90s, we had a big scare over in the UK where it was thought that, I think it originates actually from insulin injections, so bovine insulin injections that they've been using in humans, and basically this prion, which was BSE, was being transmitted, and then, but unfortunately it's one of those conditions where humans have a like. So yeah, but then there was a big ban on beef being transported from the UK to Europe, which lasted for 10 years. It wasn't particularly good at all for us. So this is a case of what it does in humans. So it's quite a lot of swelling.
It's quite lethal.
Yeah. Patients die from neurological conditions and neurological breakdown, basically. So the most dangerous infectious diseases in dentistry, we're talking hepatitis B, hepatitis C, and HIV. Lots of press about HIV, which arguably hepatitis C is probably going to be the most virulent of these three viruses. Hepatitis B, we can get vaccinated against it, so there's not much press about Hep B, but we'll just run through them all individually and just allude to a few nasty signs and symptoms that come with them. So hepatitis B mainly affects the liver, but there are other symptoms such as feeling sick, actually physically being sick, loss of appetite, flu-like symptoms like tiredness, aches and headaches, yellowing of the skin and eyes, which is jaundice, and that's generally just due to just breakdown of the area where bile and bilirubin is produced. You get these horrible blockages around your bile duct that just causes this jaundice condition. It spreads through blood and bodily fluids, unprotected sex as well, sharing dirty hypodermic needles. Some people don't know they have the virus after the exposure, but it takes between 40 to 160 days for symptoms to actually develop after the virus has been, after the host has had the viral exposure. So there's increased risk if there's more sexual partners during unprotected sex, and sharing needles like heroin abusers. They generally are the main risk groups for developing hepatitis B. In pregnancy as well, unfortunately, an affected mother can pass from mother to child, but it can be prevented if the child has vaccination immediately after delivery. So fortunately, it is curable within pregnancy if it's picked up on. So diagnosis of hepatitis B is diagnosed with a blood test, and that gives a positive reaction to the hepatitis B surface antigen. So this here is the makeup of the hepatitis B virus. On the outer surface, these protein substructures which give the identification that this virus is the hepatitis B virus. So your immune system, if you contracted hepatitis B, God forbid it, if your immune system contracted hepatitis B, your immune system would recognise that would be foreign, and then it would finally react to it, and then try to resolve it and respond to it. So the diagnosis of the blood test is in response to this positive reaction to the hepatitis B surface antigen. But the positive reaction means that the liver is actually physically releasing hepatitis B protein, and unfortunately that means that it's in a chronic stage of infection. The GP usually also performs liver function tests as well. So basically, if your liver is under challenge, the ability to function naturally goes down. So the GP will not only be testing for the hepatitis B surface antigen, but also be performing liver function tests to make sure that your liver is functioning properly. So there are two types. There's acute hepatitis B, which is the majority of cases. That generally stays in your body for 1 to 3 months. Your body recognises it and combats it. Job done. However, approximately 1 in 20 cases, the virus persists for more than 6 months, and it proceeds to the chronic stage. Now, the chronic stage, you can still pass on the virus even if not showing symptoms. 20% of those cases develop into cirrhosis, and of which 10% of those cases, 10% of the 20% that develop cirrhosis, they go on to develop liver cancer. So it's a small proportion of hepatitis B. Fortunately, there is a vaccination, so there's hardly any cases of hepatitis B in the UK and worldwide, purely because vaccination is the mainstay of the treatment, trying to prevent it before it actually happens. So as we say, the vaccination is the mainstay of the treatment, but there's no treatment for acute hepatitis B other than symptom relief. So basically you've just got to let your body go and ride it out and make sure that it combats it successfully, and it is just symptom relief. So as we said before, so headaches, myalgia, flu-like symptoms, so making sure you're well hydrated, paracetamol and ibuprofen to combat headaches, and just basically let your body ride it out. The chronic hepatitis B treatment depends on the severity of the liver damage. So again, it's all down to prevention really more than anything. Bottom line is you just don't want to get it. Either hepatitis B or C, and it's very, very rare these days. You can use medication to slow the virus production in chronic hepatitis B and prevent the liver damage. Vaccination is effective for up to 95%. It's recommended for high-risk groups, so injecting drug abusers, sexual partners, sexually active people who are unprotected sex with multiple partners, travellers to a world where hepatitis B is widespread, and also healthcare workers like us guys. It's common in parts of Africa, and unfortunately that's because of cross-contamination with vaccination syringes and inadequate sterilisation, which of course will tie in with this. The WHO estimate that in the UK it is uncommon, but they estimate that there are about 60,000 deaths a year worldwide through hepatitis B, and the majority are able to fight the virus and recover, but the majority with chronic hepatitis B have little liver damage, and therefore few cases actually go on to develop cancer. So it's a very, very small proportion that actually go and develop cirrhosis and then ultimately cancer as the end stage. So hepatitis B is basically all down to prevention. Unfortunately, there is a vaccination that we can get protected against, and that's why the cases are so low, few and far between worldwide. So hepatitis C is the more virulent one, and again affects mainly the liver. Infected only if it comes into contact with the sufferer's blood. I say only blood, it's mainly blood, because the other bodily fluids can transmit hepatitis C, but not as effective as blood-to-blood transmission. Again, if it comes into contact, symptoms you can expect to include are similar to hepatitis B: flu-like symptoms, muscle cramps, myalgia, loss of appetite, lethargy, depression, and no notable symptoms until liver has significantly been damaged as well. And the other thing as well is many people remain unaware that they're actually affected until the liver damage is significant, and you start to get the symptoms such as that.
So once you already have hepatitis C, you can't get rid of it anymore. It will always stay in your system.
Yeah, it can remain dormant. It can remain active. You might not know that you've got it. It's one of those things that you again trying to avoid the risk factors and try and avoid getting it. I would say concentrated in blood of an infected person, so blood-to-blood contact, such as sharing razors, toothbrushes, sharing unsterilised needles, like heroin abusers, transmitted also through sexual contact. It's more common in North Africa, Middle East, Central East Asia, and it's thought because of those contaminated vaccination needles for medical treatment. Tested with a blood test. The treatment includes antiviral medication to stop the viral multiplication, and this can be interferon or ribavirin, which are the main treatments to be using. Again, a very nasty drug, so it's going to knock you for six really. There are 6 different strains. Some strains respond better to treatment than others. So if you get it, you can hope that you're going to be one of those strains that's going to respond better to treatment. Okay, so WHO estimates approximately 10,873 new cases in the UK, and that was in 2012. It's estimated that 215,000 people in the UK have chronic hepatitis C, and it's more common in men than women. We guess that it's because there are more drug abusers within men than women. There's no vaccine. It's only able to reduce the risk of transmission. So, risk groups need to be educated in sterilising needles and using protection during sex as well. So risk is low in sexual transmission, but increased in menstrual blood or anal sex as well. So the first 6 months is called acute hepatitis C, and approximately 1 in 4 will fight off the infection, so 25% fight off the infection. Those remaining 75% will stay in the body for many years, and then that's classified as chronic hepatitis C. 10 to 40% of those with untreated chronic hepatitis C go on to develop cirrhosis, and it often can be 20 years after initial exposure to the virus to start with. 1 in 5 with cirrhosis will develop liver failure, and 1 in 20 develop liver cancer. And it can be complicated by other complications such as alcohol misuse as well. So the people who say are drug abusers more often not abuse alcohol as well. So not only are there going to be complications with hepatitis C from potential viral inoculation, but also they're going to be damaging the liver through alcohol misuse as well. So coming on to the last one, which is HIV. The virus it attacks the immune system, weakens the ability to fight infections and disease. HIV stands for human immunodeficiency virus. It weakens the immune system and reduces the ability to fight infections. Throughout the process of HIV attack, the end stage is AIDS, basically, which is acquired immunodeficiency syndrome. So immune deficiency, just the immune system is just down, and the body's no longer to fight life-threatening infections. And actually, it's usually pretty simple infections that kill in the end. Things like pneumonia, something that you and I will be able to fight pretty easily. It's commonly caught by having sex without protection, but also again sharing needles from an HIV positive sufferer. Mother can pass on to child during pregnancy, birth and breastfeeding. There's no cure, but treatment centres around making people's quality of life effective. So the Health Protection Agency states that 95% of those diagnosed in the UK in 2011 acquired that through sexual contact as well. So Hep B, Hep C and HIV are all pretty similar risk groups, really. So one would have thought that educating for one disease would protect against all the others as well. But it is a fragile virus, and it doesn't survive outside the body for long. It's dependent on the host to multiply the viruses, but unlike, say, Hep C, where it's really quite virulent in blood, outside the body, HIV is not particularly strong. It's pretty fragile. It's tested and diagnosed with the HIV test. The early diagnosis means earlier treatment, and early treatment is fairly successful. If it's caught within the first 3 days of being exposed to the virus, you can start anti-HIV medication called post-exposure prophylaxis. Nasty drugs, again, knocks your immune system for 6 as well. The highest rate of infection again is in UK and gay and bisexual men, but it's also with African men and women as well, and it's actually thought to originate from parts of Africa as well. Living HIV involves lifetime taking of retroviral medication and allowing a long and healthy lifestyle, so balanced diet, keeping hydrated, regular flu jabs, making sure that we're protecting against common colds and regular vaccination program. But there is no cure at all. Forgotten anything? It can't be transmitted through sweat or urine. Yep, good. HIV test done. Yeah, post-exposure prophylaxis. So you send basically a sample of the blood, and it proves to be reliable from 4 weeks from the viral exposure. So that's reliable, but you can also do a saliva sample or a pinprick with the results available in a few minutes. But they don't reliably test those infected within the last few weeks. So although the 4-week results do give you a reliable test, those exposures that have happened within there, they don't really give a reliable test, so it can be a bit of a waiting game and presumably pretty stressful. NICE recommend an annual HIV testing for men, homosexual men, regularly, so they recommend testing with the HIV test, and more frequent for those with multiple partners as well. So the antiretrovirus stops the virus from replicating, and it allows the immune system to repair itself, and it prevents further damage. Easy to resist one antiretroviral, but combination more difficult. Yeah, so the virus is able to resist one antiretroviral on its own, but that's why a combination of drugs is given to basically prevent the virus from resisting multiple drugs. Severely damaged can lead to cancer, severe infections, and late stage HIV and AIDS. So this is basically what happens. So without treatment, the immune system becomes severely damaged, unable to go and cope with mundane infections, but also these are classical signs of secondary problems that HIV infection does come to. And this is Kaposi's sarcoma here, which is dark cancerous lesions. This is what the intraoral presentation looks like a dark bluish, black almost intraoral lesion that's present, non-specified region, and you're pretty ill by this stage. This is encephalopathy, so basically brain tumours occurring. You can see how it's squeezing in on these ventricles inside the brain. And then this is another classic example of thrush, basically pseudomembranous risk candidosis. So basically the immune system just can't combat the regular commensals in your mouth, and then basically fungi just basically go rife, and this is the presentation. Similar presentation to asthmatics and people with denture issues. But
so you could clearly see the signs in patients' mouth.
Yeah, but you got to
they're quite late stages.
Late stages, yeah. That's the point. Is that the immune system slowly over time dies off and it becomes severely damaged. There's a classic chart that they produce, and there's white blood cell count, and over the stage of the course of the HIV infection, the white cell counts slowly go down. White cells are essential for your immune system. Slowly goes down, and then ultimately they're unable to prevent against these types of secondary problems. So HIV affects 98,500 people in the UK in 2012. As we said, the majority of those people infected were through sexual contact. 41,000 in gay and bisexual men and 53,000 heterosexuals. 1 in 5 don't actually know that they're infected. That's the scary part about all of these conditions, is that a lot of the time you might have you might have contracted the virus, but you're not actually aware of it, and it can manifest later down the line. 1 in 650 people in the UK have HIV. Approximately 1 in 20 gay and bisexual men have HIV, and approximately 1 in 25 African men and women have HIV as well. The WHO state that there are approximately 34 million people in the world living with HIV. That's probably why it's more publicised than Hep C, because there are more people that are affected by it. But actually, it's a much more fragile virus to survive. It's more common in sub-Saharan Africa, and again, similar reasons for that as well. So we've touched on background microbiology and what we're trying to prevent against in dental practice. More specifically, we'll turn our attention to the second topic is going to be about the legislation involved with dental practice, and what the government have basically produced for primary dental care to allow us to have standards of decontamination and develop our practice to prevent cross-infection between patients and staff and patients. So this section, we've identified the aims as being that you as a learner will have an understanding of the legislation surrounding the decontamination process in primary dental practice, and that you'll understand the various ways of minimising infection transmission. And our learning objectives, quite a few. We're going to recall the documentation relevant to effective infection control in primary dental practice. We're going to describe the different stages involved in the decontamination process and explain the process of infection control within the surgery as well. We're going to differentiate between the different types of autoclaves and the way that they work. We use a particular type, but there are others available, and there are pros and cons to both. And we're going to evaluate the differences between hand scrubbing, ultrasonic rinsing and sterilisation. And we're also going to be able to critically appraise decontamination processes as well as plans for sterilisation facilities. Did you have any questions about the first stage?
No, I think I'm good.
Oh, right. Okay.
Definitely
Fine.
following the log.
Fine. Good stuff. Good stuff. So the main overarching document that the Department of Health have come out with is this, which is the Health Technical Memorandum. It's 01. That is an overarching umbrella for multiple documents. The one that's relevant to primary dental practice is 0105. 02 alludes to decontamination in laboratories. 03 is decontamination in pharmacies. But section 5 is specifically about primary dental practice. There was a previous edition in 2009, but it's been superseded by the 2013 edition, and that was mainly due to issues with instrument storage. The 2009 document was just ridiculously stupid, so they've developed that, and they've acknowledged that, so there are differences between that because of that, and we'll come on to that in a couple of seconds. It alludes also to what's essential practice, so what you as a practice have to achieve, but then also if you are commissioning new services or if you're moving premises, you have an obligation to go and move towards best practices. So if you're setting up a brand new practice in new facilities, you have to go and comply with best practices rather than achieving essential practice. And the infection control policy requirements are in there as well, and we'll come on to that. There's a bit of a list, but we'll run through that as well. So decontamination is the process by which reusable items are rendered safe for further use and for staff to handle. Decontamination is required to minimise the risk of cross-infection between patients and patients and staff. The process is also known as reprocessing. It's a complex process. It involves several stages, and that includes a separate stage for cleaning, disinfection, inspection and sterilisation. So the key features of essential practice are there should be a validated decontamination process. I've got to admit, within the decontamination process that we use in practice, there's only really the sterilisation that you can actually validate, and we're currently looking at that to try and improve that on the back of the dental foundation training inspection. At the end of the process, the instrument should be sterilised, and that should be consistent for every load that you're putting on. We should also include an infection control policy, and as I say, there's a bit of a list on what an infection control policy has to entail. The practice does comply with them all, we've checked it through and through, but basically it should include a written policy regarding the risk of minimising the risk of blood-borne transmission, and that's also including occupational health arrangements. So in the event of an occultation injury, Sharp's injury for instance, we know where to go and send you to go and get checked out. Policy on the decontamination process, which we're going to come to in a few moments. Procedures for cleaning, disinfection and sterilisation, management of clinical waste, and you have to have contracts and agreements between ourselves and clinical waste providers, and then also transfer notes to make sure that the waste has been, you basically need to prove that you're compliant. A policy for hand hygiene, a policy for decontamination of new instruments, the local usage of PPE, so making sure that you're wearing the appropriate gloves, masks, visors, all that stuff. The procedures for the management of dental instruments, recommended disinfectants to be used in practice, a spillage procedure, and local policies for environmental cleaning. So all the duties that we try and incorporate within the rota on a weekly basis, making sure they're given the opportunity to go and wipe the surgeries down, wipe the walls down, wipe the floors down. You know, that's all engulfed in this infection control policy, and that's dictated by the HTML 105 document. You need to have a lead team member on infection control, and I believe that's Russ, as with all policies and protocols, thank goodness. You need to have clear protocols on single-use and reusable items, so there needs to be clear definition with what we need to sling after the end of a session, and also what can be sterilised. So things like root canal files, for instance, is the classic example. Make sure that if you finish using them with that patient, sling them away. If they're sling use, you can't put them through the autoclave. You should incorporate a cleaning and inspection phase, so we use the manual cleaning and the magnification. And the decontamination should take place in a separate place to the clinical activity, hence why beforehand we had the autoclaves in the surgery, now we don't. They have to be in a separate place. Fine. So I said that there was a change from the 2013 edition to the 2009 edition. It mainly comes down to instrument wrapping. So in summary, the wrapped instruments may be stored for up to a year. So as long as it's gone through the sterilisation process and it's wrapped, we need to stamp it to make sure that there's an audit process involved. But those wrapped instruments may be stored for up to a year. Unwrapped instruments in the clinical area, as long as they're under a lid or in a drawer or in a cupboard, and they may be stored for up to a day in a dry, protected area, free from contamination and reprocessed at the end of the day. So if it's not used, it's still in the cupboard, doesn't matter. If it's unwrapped, it needs to go through the autoclave again. Unwrapped instruments in a non-clinical area though, if you were storing the instruments in the decontamination room, they can be stored for a maximum of a week. So cleaning, I think I talk about 3 different stages. So there's cleaning with a washer disinfector, which is best practice. Cleaning with an ultrasonic scaler, ultrasonic bath, thank you, and also manual cleaning. So one's more effective than another, that one's more effective than another. So washer disinfector is best practice. So using a validated washer disinfector, it's good because it gives you validation that that washing phase has been successful, that the temperature has been maintained, and that it's gone through a whole cycle. So typically within a washer disinfector there's 5 stages, and you don't need to remember this, but there's a flush stage, so it initially removes gross contamination. It maintains the water at less than 45 degrees because it prevents protein coagulation onto instruments, and that makes it harder to go on clean off. There's a wash stage, removing remaining soil using a suitable detergent. There's a rinse cycle, so that it removes the detergent used in that cleaning stage. Then there's a thermal disinfection stage, where the temperature is raised and held at a preset disinfection holding temperature. And for instance, that can be 80 degrees C for 10 minutes. And then there's a drying stage, where it purges the load and chamber with heated air. It removes all that residual moisture, so it basically dries it completely. So at the end of the washer disinfected stage, you'd hope that it'd be disinfected, but it wouldn't be sterile. But then you'd be able to validate that disinfection stage as being completed and the washing stage would be completed. Not as effective is the ultrasonic bath cleaning. You can validate this to a point, but it's not as concrete and belt and braces as, say, the washer disinfector is. It's really important to change the water and maintain the unit regularly. It's proven to enhance debris removal compared to manual cleaning. It's frequently tested according to the manufacturer's instructions to make sure that the water's being agitated sufficiently. And the instruments should be immersed in the cleaning solution. You should dismantle all the instruments fully, place the instruments in a basket and fully immerse in cleaning solution, and then set it to the correct timing, and then make sure it's drained after the cycle's finished. After that cleaning, sterilise as soon as possible. Although I'd probably suggest to do a manual clean as well after the ultrasonic bath cleaning. The problem is with ultrasonic bath cleaning is that it can take a good few minutes for it to clean, and the problem is if you've got material that's stuck on there, if you've not actually physically had a scrub beforehand, it may not come. So you might want to swap the manual cleaning with the ultrasonic cleaning, or
it might be good to do the manual cleaning
first,
and then
rinse it, and then put it in the ultrasonic bath to agitate. And that would probably be the best way to do it. And then the least effective is the manual cleaning. It's the hardest method of cleaning to validate. You can't say for sure that you are doing exactly the same scrub every single time. So you can't validate it. It also presents a great inoculation risk. Stabbing yourself in the water is pretty easy when you've got loads of sharp instruments inside the water. And best practice standards should seek to reduce manual cleaning protocols. So if you are setting a new decontamination facility or community premises, HTM 105 would kind of want you to eradicate manual cleaning completely and to then go and use a washer disinfector to go and do that. We don't use a washer disinfector at the minute. Number one, because it's not mandatory. but also we just don't have enough instruments to go and do it. It's something we would look at in the future. Should legislation change to say that we need to use washing disinfector, then of course we'll go and do it. And the washing disinfector takes a long time as well. You're talking a good 10-15 minutes for a cycle to be done, and 10 to 15 minutes in the grand schemes of a sterilisation cycle already, it just adds a lot of time on, and there's no proof as well that it's actually effective. So after cleaning, so once the cleaning is taking place, you've got to inspect them, you've got to discard any defective instruments, and inspect the instruments under magnification to ensure you've effectively cleaned them. Make sure that all that debris is off, make sure that all the blood off, and gunk and materials off. Handpieces should be adequately, but not excessively lubricated prior to sterilisation. So we come on to sterilisation. Finish that. So sterilisation is usually performed through an autoclave, or uniquely performed by autoclaves. It's a saturated steam that's put under pressure, and that achieves sterilisation. It may take place after cleaning and disinfection. So you've got to get all that cleaning and disinfection out of the way before you then go and put the instruments in the autoclave. And the big thing is it's validated. This is the part of our decontamination process is validated. We've got a data printer, so we get a print off to say that the autoclave has maintained temperature for the right time and at the right temperature. There are essentially 3 different types of autoclaves. The first 2 are the most popular. The type N1 is a vacuum autoclave, so air is removed by passive displacement with steam. Sorry, that's non-vacuum. That's a non-vacuum autoclave, and that's the type that we've got. So we've not got a vacuum autoclave. The second type is a vacuum autoclave. There's a lot more to go wrong on a vacuum autoclave, but the beauty of the vacuum autoclave is that you can stick instruments in that are in their pouches, and also it draws that sterilised air through air cavities, so basically through handpieces and drills and through aspirator tips and syringes and all that. There's a type S, but they're not particularly common. They're specifically designed to reprocess specific load types. Don't ask me what load types, I'm not sure.
It's one of them was specific for hospitals, I think.
Probably, yeah, probably. I guess so, because hospitals have such a large quantity. I bet you're right. It would be something to do with hospital setting. So this is the model best practice decontamination facility, similar to Leppings Lane. You know, we've got a dirty side here and a clean side. So instruments come in. Throughout the whole facility, there's ventilation extracting dirty air and pumping it outside, and also we're not pumping dirty air into the clean side. So there's a definite logical process involved. So the dirty instruments come in. There's a washing sink, ultrasonic cleaner, and then putting it into the washer disinfector. Then it's a double-ended washer disinfector that separates the clean side to the dirty side. So in the dirty side, you put the dirty instruments into the washer disinfector, and then there's another door in the clean side where you go and put your washer disinfector on, pull those out clean, and then it's completely, aseptic. Don't need to worry about anything else. We have a logical process where the instruments come in through the decontamination room from the dirty side right through to the clean side. It's not best practice, but we comply with essential practice. Okay, so that's the legislation involved with infection control in dental practice. We're just going to look at the actual process that we've got here, and we'll look at critiquing it, and we'll see what we can do to improve it, see whether there's anything we can do to improve within reason, and see if we can't pick up on a few bits and bobs. We've already mentioned something earlier. The aims of this demonstration section is to basically make sure that you are able to consistently perform instrument decontamination to a high standard and consistently. That's the big thing. Consistently do it from process to process. And you've got to also demonstrate thorough and meticulous surgery hygiene procedures as well, which you do already anyway. The learning objectives of this one is to operate consistently to a high standard, maintaining your up-to-date logbooks and sterilisation records, but then also to evaluate the policies and the procedures currently employed by us and propose changes if necessary. So we've got our posters from the decontamination room here. So HTM 105 stipulates that we transfer our dirty instruments from the clinical area to the decontamination room. They say that we should be using a watertight, sealed box, and it should be clean and completely aseptic. So you can see that we've developed this, and we were involved with doing this anyway. So you take your clean, dirty instrument box from the decontamination room. So you've got to imagine that it's already been cleaned in the decontamination room. You're bringing a dirty box into a clean area, so you want the outside of the box to be clean. So you're bringing that into the surgery environment. You put your gloves on, and then transfer those dirty instruments from your sink to your dirty box. So once that's finished, take off your glove, put your clean box lid onto the dirty box, but the outside is still clean. So we're complying with HTM 105 by saying that we need to transfer the dirty instruments from the surgery area to the decontamination room, because we have the dirty instruments inside a dirty box, but the outside is clean. So we're okay on that.
Yes.
Where we fall short on is where?
Manual cleaning.
Because
it's hard to validate manual cleaning.
Excellent, good stuff. So we can't validate the manual cleaning. We've said that we can't say for sure that we are persistently doing manual cleaning effectively and efficiently every time. The only way that we're going to be able to validate it properly is with a washer disinfector. So we fall short on that. At the minute we're looking to do the ultrasonic cleaning as well, ultrasonic bath cleaning. So whether we incorporate that as part of the manual cleaning after we've manually cleaned, that's probably something we'll probably look at doing.
Yeah.
So when the clean, dirty boxes come from the clinical area into the decontamination room, wash your hands, you don on your PPE, so you put your apron on first, put your mask on, visor, gloves, and then your heavy duty gloves over the top. So then you've got your PPE ready, you go and clean them, make sure that all the GIC or blood or whatever's on the instruments is removed, and then basically you need to lubricate your handpieces before you sterilise them. Rinse them, so you've got to remember you've got disinfection inside the sink. So rinse off the disinfection solution, but it's really important you inspect them. So make sure that you're getting rid of all the stuff, inspect them, make sure there's no blood left on there, make sure there's no debris on there. If you see anything, just repeat that process.
Right.
So then once you're happy that you've gone and done all your manual cleaning, then you're ready to go and put the autoclave on. So the rinsed instruments need to be put into the autoclave, turn the autoclave on, and then you do your wind down. So you empty the sinks, rinse it all out, clean the brushes, put your heavy duty gloves on, take your PP off, and then wash your hands afterwards. Any questions?
I think we definitely should get that ultrasonic bath.
I
That's a
agree.
good idea.
I agree. It's very difficult to validate, but where a process is lacking in validation, I agree. And in all fairness, when the foundation training people came in to inspect us, they made that suggestion that we hadn't had an ultrasonic bath in place. They also acknowledged the letdowns of wash disinfectors as well. So they actually said that there's hardly any dental practices using them in the area because it's not mandatory, because it's not proven, and because we just don't have the throughfare of and the quantity of instruments to accommodate. So yeah, I think it's a sensible idea to do that. Wonderful. And a biscuit?